Our next speaker is Janet Lin, who is an associate professor in the Department of Emergency Medicine and has an affiliate appointment in the Division of Community Health Sciences in the School of Public Health. She is also the Director of Health Systems Development in the Center of Global Health. She has earned certificates in tropical medicine, has consulted on global issues, and her work has taken her to Latin America, Africa, and Asia. Dr. Lin heads the International Emergency Medicine Fellowship Program in the UIC College of Medicine, which trains postgraduate physicians to practice and do research in international settings. She's also a UIC alumna. Please welcome Dr. Janet Lin.
I would like to take the next 6 minutes or so of your time to share my story. It draws from my heritage, my culture, both urban and international, and my education. It has shaped who I am today, but also my academic career. This is my path to community engagement. I was born into a classic Chinese American family, academically driven, but also wanted to fit in as a typical American kid. We played sports, ate pizza, like any other kid, but being the only Chinese family in an all-white school and looking different was trying at times. Looking back, the uniqueness of our upbringing was probably why I appreciate the nuances of people, language, and culture today so much. I always loved to travel and find out about places where my dad had come from. In fact, I still have many of the trinkets that he would bring home from faraway places. As I grew older, the travel bug bit me too. So I spent time in Taiwan, in France as an exchange student, and a summer on the Panama Canal at the Smithsonian Tropical Research Institute studying tropical ecology. You may ask, why tropical ecology? I include this just because this was the first time I was really able to see how I might combine my interests of travel, language, culture, and biology together. I finished college with a degree in biology and French, proud that I was fluent in another language, and entered medical school here at UIC. In fact, not only am I an alumna of the College of Medicine class of '99, I've also done my specialty training here in emergency medicine and my subspecialty training in international emergency medicine, and subsequently stayed. So today I'm faculty here doing research, education, and service. So where am I today exactly? My research interest and my passion is in improving healthcare and delivery of care in resource-limited settings. I work with strengths which are most often rooted in the people and the community, but sometimes also created through a technology like cell phones or a response, as in disasters. Guatemala will always have a place in my heart because of its natural beauty and the indigenous people with whom I worked. And it is a place where I started my global health work and where I was first introduced to health promoters, a model of care that relies upon community lay people to provide the first line of healthcare in often ignored areas of the country. From that experience, I've been building 2 programs, one in Haiti, focusing on community engagement and disaster risk reduction, and another in Uganda, looking at how volunteer health teams, essentially lay health workers, can improve access and quality of care in a rural clinic. While both are equally close to me, I'd like to focus on my work in Haiti tonight. My first introduction to Haiti was for immediate disaster response. I was part of a team that went down 2 weeks after the earthquake, after seeing the devastation of an already fragile country, and because of my formative work, I felt that it was important not just to provide the acute disaster aid, but to return to try to find ways in which to empower the Haitians in their recovery. A year later, I returned with a team of residents, nurses, and students to a displaced persons camp in Carrefour to provide needed health care, but also conducted an assessment of health needs post-earthquake. Doctors Without Borders had just left the clinic about a month prior to our arrival, leaving a gap in any type of medical care. This is Ronnie, a Haitian physician we worked with in the clinic. For the assessment, we reviewed over 2,000 patient encounters seen in 6 days and conducted 144 household surveys in the tent camp. Primary health issues included access to clean water, women's health, and chronic diseases. In addition, people were concerned about their livelihood and safety, like shelter, food, and employment. As volatile as the political situation in Haiti is, we couldn't return to the camp the following year. The camp had been disbanded, the UN had to get involved, and even today, remaining residents report human rights violations. So we moved to Delma, another commune in Port-au-Prince, where Ronnie has lived and worked. Today, we continue our work in this community. We started with a disaster preparedness assessment of the community to familiarize ourselves with the people and the area and to see, after 2 years, what kind of progress had been made. Despite the local government's good intentions, roads were impassable, formal public disaster plans were lacking, and promised resources had not been allocated. However, Haitians have strong family and social support networks within the community. Given all these findings, we worked to create a community-informed training program that draws from these strengths and empowers the people to take the initiative to reduce risks to various hazards and disasters that they might be susceptible to. First, we created content that was piloted with community members to see if it was acceptable. Some of these were mapping exercises, games like telephone that you might remember as a child, and photo voice, where we handed out cameras for them to take pictures of their environment to see what they understood as hazards, risks, and vulnerabilities, From this, we created a modular community training program covering 3 areas. And these 3 areas were defining hazards, risks, and vulnerabilities, like no electricity, no roads, no reliable healthcare, identifying protective factors and community assets, and developing strategies within their existing capacity to assess and manage environmental threats. Many community members who tested the initial activities wanted to become leaders themselves. So of the 42 people who piloted the activities, 16 received this training. Post-training, they were able to identify community assets. All of them found the topics relevant, and they developed useful skills. And in fact, from my communication with them in December, half of them have actually gone on to do trainings themselves. As a result, all the participants developed next step action plans for them to continue their work. We recruited Haitian research assistants to help with logistics and data entry, and we developed new academic and local partnerships to expand content to include areas such as mental health. In March, we'll return and plan on using some of our newly trained Haitian community leaders to help train and test adaptability of this program in another neighborhood. This neighborhood is actually where one of our translators is from. He was so excited to be part of this program that he asked specifically for us to bring this program to his community. This is what community engagement is all about. Partnerships are paramount to any success, not only with colleagues from other disciplines like mental health, education, social work, but also with the people I'm trying to help. Ultimately, ownership of the process is what I aim for. If I can share my knowledge such that Haitians are able to, quote, take it and run and put me out of a job, that's my ideal. While not a short road, I hope it's attainable. Mission Pile.